I think we're live now. Just if uh, people can see this, can you send a comment or something? Oh, I don't know what's okay. Think we're now live. Sorry for the delay, everyone. It took a bit of time to get this all set up properly. Okay, so if people can see this screen and hear me, just send a type of comments just so I know that people can see and hear me. Okay. Yeah, okay. I think it's okay. Looks like it's working. Okay. So, yep, perfect. Can people hear me properly? Just making sure that the audio is all good and everything as well. Okay. Thanks, Michelle. I can see your comment. You can see it. Beautiful. Okay. That's my first time doing a Facebook Live like this, so thank you all for tuning in. So let me just get all this running. Okay. I'm just going to enlarge my screen here. All right. Well, let's get started. So, yes, my name is Dr. Damian Teo, and I'd just like to thank Sleep Disorders Australia for inviting me to talk to you tonight about mandibular advancement splints. So, I'm a specialist dentist specializing in the field of sleep apnea. So, I see patients every day for snoring, sleep apnea, teeth grinding, and jaw pain issues. So I also have a graduate diploma in dental sleep medicine, and I've been doing this over the last 7, 8 years. So please, if you have any questions during this presentation, I'm going to be answering them at the end. So please type them up in the comments box. At the moment, I won't be reading the comments at the same time. So if you, sorry, just had to check that. So if you do have any questions, please ask them all at the end and I'll answer them later. So, to start off, I just want to mention that sleep apnea is a health issue that has many different risk factors. So, if we're male or overweight or we're older, or if we do have habits of like smoking or alcohol use, these can increase our risk of sleep apnea. Now, I bring this up to all of my patients because quite often most patients come and see me for a MAS and think they have the idea that the MAS will fix everything. Majority of the time, the MAS will improve everything and make them sleep better and treat their sleep apnea. However, if they're overweight or if they smoke or drink a lot or if they have like nasal congestion or other issues going on, the MAS or even the CPAP is only just going to help so much. So I tell all my patients before I treat them that yes, what we are doing is definitely going to improve things, though it may not fix everything. And that's very important to note in these situations. So another thing I talk to all my patients about when I give them a MAS is we have to achieve 3 things to help them treat their sleep apnea. We ideally want them to be able to close their mouth so they can keep their lips together, breathe through the nose, and keep their tongue on the roof of the mouth. If a patient can achieve all 3 of these things, then they'll have a better chance of treating their sleep apnea and feeling more refreshed during the day as well. So, how do we manage sleep apnea? Quite a few different modalities we have available, not just CPAP or appliance. So, Firstly, there are conservative things we can do, such as weight loss or exercise, sleeping on our side, reducing any drinking or smoking, improving our nasal patency if we have allergies, or using nasal sprays or tablets, practicing good sleep hygiene. So we could have a CPAP or a MAS, but if we're not sleeping, having good sleep habits, such as we're going to bed really late and waking up inconsistently, if we're sleeping in a room that's not completely dark or noisy, etc., these sort of things will make us feel tired and not give us good quality sleep. And then there's also things such as like facial exercises, which are to train the lips, the cheek, and the tongue to get stronger. And even things such as like there's even research showing that singing and playing the didgeridoo can help sleep apnea. And then there's active management, which is where doctors and dentists can step in to help. So we can offer things such as CPAP or oral appliances, or sometimes we may need to do surgery, such as like removing tonsils or adenoids or cleaning up the nose or sinuses. And then over the last few years in dentistry, it's orthodontics or using braces has become more and more popular to help treat sleep apnea in kids and adults. So these days, more and more dentists are now using braces to not just straighten the teeth, but to also help grow the jaw and improve the size of the mouth. If the mouth is bigger, there'll be more room inside the mouth for the tongue. And if there's more room for the tongue, there'll be more room in the airway. So CPAP is the gold standard treatment for sleep apnea. It applies a constant pressure to the upper airway, acting as a pneumatic splint. So basically, when you apply pressure with the sleep apnea machine, it pumps air down our airway and the air pressure opens up our throat so we can breathe better. Now, with sleep apnea, there's mild, moderate, or severe sleep apnea. And we use these numbers from the AHI. This is a number of times you stop breathing during the night. Anyone who's 30 and above means they have at least 30 times an hour they stop breathing. Now, people with severe sleep apnea are normally recommended to use a CPAP. In mild and moderate sleep apnea, CPAP is also recommended. But in these circumstances, some people may not be able to tolerate a CPAP machine. And that's where appliances such as Mandibular Advancement splints can come into play. So when we're looking at the research into efficacy of both CPAP and MAS, there's this study which comes up from Flinders University in Adelaide. And they looked at 2,700 CPAP users from 7 countries. And it is well known that sleep apnea is associated with heart issues such as high blood pressure and stroke and heart disease. And most of the time, we find in the research that CPAP and MAS can actually help reduce high blood pressure and heart disease. But this big study, they were actually surprised not to find a reduction in cardiovascular events from CPAP. So this is very important to note because we know CPAP is a gold standard treatment for sleep apnea. However, we do have research showing that, yes, it may be treating sleep apnea, but it may not be able to help reduce the other side effects related with it. And this is big news for us to take in because that's where things outside of CPAP and MAS may be needed, such as weight loss or clearing up the nose, etc. So one of the biggest issues with CPAP is it has a very low compliance rate. The research shows that less than 8% of patients are able to use CPAP, and those that are able to use it can only use it for maybe 3 to 4 hours at night. Now, the thing is, with when we sleep, we should ideally sleep for 7 to 8 hours. But if we're only able to use a CPAP for half the time while we're asleep, we're still going to feel unrefreshed in the morning. We're still going to have the risks of heart disease and stroke and high blood pressure. So low compliance with CPAP is due to a few factors, such as it being uncomfortable, not appealing to wear at night, being noisy, it's not travel friendly, so people who travel a lot or go camping, you can't really take around easily, and it can cause a dry mouth and nose. And a personal story for myself is I was diagnosed with sleep apnea about 8 years ago. And then I was given, of course, given the options of either CPAP and a splint. And this is how my journey started into going down sleep apnea. I was diagnosed with it and wanted to treat myself. So I saw I didn't want to use a mask like this for the rest of my life. And I saw, hey, I can make this mouth guard for myself, which fits in the palm of my hand, convenient to use, and very easy to wear at night when I'm sleeping. So let's say you've been diagnosed with sleep apnea. What do we do now? Where do we go from here? So if we go look into the guidelines for oral appliances, the literature is only filled with guidelines and recommendations on how to treat and what to use. There's no set standards in oral appliance therapy. So in dental university training in Australia, we're not taught how to make mandibular advancement splints, or we're not taught a lot about sleep apnea in our 5-year undergraduate training. We're mostly taught how to do drilling and filling, etc. Most dentists who treat sleep apnea get the training after they graduate from university. So for myself, after I graduated from 5 years of dental school, I started doing courses and trainings and residencies in sleep apnea. And there's lots of different courses out there and lots of different training levels. So there's no really set standards in sleep apnea treatment with a MAS. But the main consensus with these guidelines is conservative management and CPAP must be trialed first, because as dentists, we're treating a health issue with a dental device. So when we look in the American Academy of Sleep Medicine guidelines, these are the most current guidelines, which are from 2015, and they get updated regularly. So the guidelines say that although CPAP is the first-line treatment for sleep apnea, MAS is an effective alternative that is preferred by some patients. So they recommend that any treatment is better than no treatment. So if you can't use a MAS or you just don't like it, there is still hope that there is something out there which can be used for you. So when we look into the guidelines, they have two classifications on when to use a MAS. They have indications and recommendations. And the detail in this language is important mostly for us dentists on when we can use a MAS. So with the indications, they indicate to use a MAS in people who snore or have mild to moderate sleep apnea who prefer a MAS or who can't tolerate CPAP or are unable to use it. And then with the recommendations, they recommend a MAS in severe sleep apnea patients. So if you have severe sleep apnea, they indicate that you should trial CPAP first before using a MAS. And if you can't use a CPAP or you just don't like it, that's when you have to go to a MAS. Now, I see some patients where they can't tolerate a CPAP and we use a MAS on them. And the MAS works. However, it may not bring their AHI all the way down to 0. I've seen patients where their AHI is 80, and we use a MAS and it brings it down to 20. Now, at 20, there's still a moderate sleep apnea patient, and my splint can't bring them down to 0 anymore. So that's where other factors may need to come into play. So if they're in these categories, they may then be able to use a CPAP with the MAS. So that's combination therapy of using both a MAS and CPAP. Other patients, they may need other help such as weight loss or exercise, sleeping on their side, cleaning up the nose, surgery, etc. So CPAP and MAS are great treatment modalities, but there can be some limitations depending on our other overall health issues. So remember, any treatment is better than no treatment. So looking at some of the research with a MAS, this study from this year was looking at moderate and severe sleep apnea patients. And they found that MAS was effective in patients with moderate or severe sleep apnea and was able to reduce the average AHI down by about 64%. And this was influenced by our people's weight or the body mass index. So weight is very closely related with sleep apnea. If you've got normal weight or if you're overweight, it can influence your AHI. And in this study, what they found, people with moderate or severe sleep apnea who were of an average weight, they were able to reduce their AHI a lot greater. But if you were more overweight and you had moderate or severe sleep apnea, they weren't getting a significant reduction in AHI. So this is where it shows that a MAS can be very effective in moderate or severe sleep apnea patients. So those guidelines from 2015, most likely they'll be updated again in the future, and it might show that MAS is very effective in severe sleep apnea, and that there are other health issues involved, such as our weight, our diet, our nose, etc. So looking into more of the research as to whether MAS does work, this study shows that using MAS actually does help reduce blood pressure and depression. And this second study also does show that there is a reduction in blood pressure using a MAS, very similar to a CPAP therapy. So we do know that a MAS is very effective, and it can help not just with our sleep apnea, but with other underlying health issues related with sleep apnea. So most of you probably wonder, what does a MAS look like? So this picture here, this big picture on the left is a MAS, and this one on the bottom here is a grinding splint or a mouth guard. So the MASs I tend to use look like this, a bit different from the one on the other image. So the difference between these is a grinding mouth guard or splint normally just goes on either the top or bottom jaw. So it's just one piece, and it's normally completely flat. Whereas a MAS, it normally goes on the top and the bottom jaw, and it has these arms or a mechanism on the side to help hold your bottom jaw forward and push your bottom jaw forward so it opens your airway. So before we go into MAS, let's just talk about a splint, because I'm sure most of you have been wondering, why do I have to use a special mouth guard? Why can't I just use an over-the-counter splint or a normal splint my dentist makes? Well, these splints aren't effective for sleep apnea, and in actuality, they can actually make sleep apnea and snoring worse. There's this study which looked at sleep apnea patients, and they gave them a splint. And what they found, when they gave these patients a splint, it made their AHI and their snoring a lot worse by more than 50%. So the reason these splints can make your sleep apnea worse is you can't breathe properly, and then you put a piece of plastic in your mouth, which makes your airway even smaller and makes it even harder to breathe. So if we're putting more stuff inside our mouth and we can't breathe properly, it's just natural that it's going to make our sleep apnea a lot worse. So a grinding splint can make your sleep apnea worse. So how exactly a MAS works is, if our airway and bottom jaw is collapsing backwards, the MAS is designed to hold the bottom jaw forward and keep this airway open. And this is how it looks on an X-ray from someone on the side on. This is the throat, the top and bottom jaw, and this is the tongue. You can see if the bottom jaw is pushed forward, it opens the airway so you can breathe better. So this is an example of one of my patients where I used a MAS on. You can see from the side view, the bottom jaw is quite far backwards, and when you put the MAS inside, it brings the bottom jaw forward. And this is another patient. You can see her bottom jaw is a lot more backwards than the other patient, and when you put the MAS, it brings the bottom jaw really far forward. So that's going to open her airway a lot more. And the benefit of this is it's also going to protect them teeth if they're clenching or grinding. Now, which sort of MAS should I use? That's normally the next question I get from all my patients. So there's many different designs of MASs out there. It's sort of like trying to decide, what sort of phone should I get? Should I get the new iPhone or Samsung or Google, etc.? So in terms of choosing a MAS, it's a joint decision between yourself and a dentist. When you get a MAS, there will be many factors involved in determining which design is best for you. These factors vary from dentist factors and patient factors. So on the dentist side, it can vary on what sort of MAS they've been trained to use and what sort of materials they have available, and what sort of materials their lab uses. On the patient perspective, it can be what's comfortable for you. Do you have any missing teeth? Do you have any gum disease, etc.? So when we classify oral appliances with all these different designs, there's twin blocks and monoblocks. So twin blocks are where they're made in two pieces, and monoblocks is made when they're made in just one piece. Then they can be custom fit or one size fits all. And then they can be either made by a dentist or over the counter. So looking back into the guidelines for an oral appliance, what they recommend is an effective oral appliance must have a mechanism which allows the bottom jaw to be pushed forward and backwards if need be. So the ideal features of a MAS should be adjustable in maximum 1 millimeter increments forwards and backwards. It should be comfortable, it shouldn't be too bulky, and should be a custom fit and long lasting. We want something that will, because if you have sleep apnea, most likely you'll need to wear this mask all the time you go to sleep. So we want something that will last many, many years, not something that you have to keep replacing every few months. So as I mentioned before, the decision or choice into what sort of mask you get is a joint decision between yourself and the patient. So when you get a mask, we normally need to check a few things to make sure you're suitable and see which design will be best for you. So we check if you have a crooked jaw. We check if you have jaw pain or clicking in your jaw joints. We have a look if you've got a big or small tongue. We have a look if you have any teeth missing. So in this patient, they have no teeth at all. So we have to use a very altered design. We check if you have any tooth decay or gum disease, because these are all factors which will impact whether we can use a mask on you and what will be the best design for you. Now, in terms of I'm now going to talk about different masks that I use. Now, full disclosure, I have no financial incentives given from any companies or labs. I use private dental labs who give me no sponsorship or incentives for promoting their products. And I think the labs I use, they don't even know I'm actually going to be promoting or showing their products here. So there are over 50 different types of masks out there, and I have not used every single mask on the market. So there may be dentists out there using a different design than me, and they're doing it just as well, or maybe even better than me. So the advice and discussion I'm going to give next is from my personal experience of what I have used and what I find works best in the patients I have seen. So let's first talk about over-the-counter ball and bite appliances. These are generally cheaper, but are they more effective? They generally have no or a very limited way of adjusting the jaw forward. They're not custom fit, or they have a very limited custom fit. And they're normally a one-size-fits-all, so very bulky and large. And they're mostly made of a very soft material, which falls out of the mouth and can break easily, and it's very uncomfortable. They can be very uncomfortable. So we have to then ask, why do these over-the-counter cheaper options exist? Well, we live in a consumer world where if there's an opportunity to sell a product or make a product for us consumers, people and companies will take advantage of it. So just like in this coronavirus situation, people started hoarding toilet paper and now they're selling it for outrageous prices. That's the same thing. I see these over-the-counter splints as a very similar aspect. I see there's an opportunity to make these mass-produce these appliances that they can just sell over the counter in any pharmacy. And we have to think: do they really have our best interests at heart here? So this was a very popular over-the-counter splint that was in the market in Australia a few years ago. Now, this screenshot, I took it just today from Harvey Norman. It was since banned from Australia because of their marketing, and however, it's still available in New Zealand. Now you can see the price; it's quite a hefty amount of money still, $350 for a ball and bite over-the-counter splint. And you have to also wonder, why is Harvey Norman selling one of these splints? Like, they're a furniture and electronics company or shop. Why are they going to the realm of where doctors and dentists should be working? Why are they selling something that is treating a health condition? Are they actually qualified to be selling something like this? So with this Apnea RX, there's actually this review from a sleep scientist, Lana Ayington, online. And she broke down and really broke down the promotion material and advertising material for this splint when it was first released. So The advertising material, a video for Apnea RX said it's recommended by the American Academy of Sleep Medicine and American Academy of Physicians. Now, she found there's actually no such organization as the American Academy of Physicians. So you have to wonder, are they just making things up to just market something to us? And then secondly, she contacted the American Academy of Sleep Medicine to verify if Apnea RX was an internationally recognized by this organization. And the AASM said they do not recommend any specific oral appliance and they will contact Apnea RX immediately. So looking more, they found the American Academy of Dental Sleep Medicine recommends a qualified dentist use a custom titratable appliance over non-custom oral devices. So Apnea RX and other ball and bite over-the-counter devices do not meet this criteria. So you have to think, really think, when you're diagnosed with sleep apnea, yes, there are cheaper options, but do they really have our best interests at heart? Are they really going to fix your problem properly? And are these really effective appliances, or are these just something that a company just made just to take advantage of us consumers? So this is a photo I took of a demo, one of my masses that I make, and over-the-counter one-size-fits-all splint that you can get on the market. So you can see the difference in quality and material. This material is very soft and malleable and flexible, can be torn up quite easily. And you can see it's very thick as well compared to the custom-made dental splints that I make. And you can see the custom-made dental masses, they can actually be adjusted to push your jaw forward. With this one, you can't really push your jaw forward, and other designs, it's very limited in how much you can push your jaw forward. So there are also temporary dental masses out there. So some patients ask me, can't I just use this temporary mass, which is cheaper? And they can, but remember, it says it in the name, it says temporary. These are generally designed to be temporary. They're not long lasting. They're only designed to be used for a couple of weeks or a couple of months. So yes, they're a great thing to use at the start to get used to something in your mouth or see if it's actually going to work for you. But then long term, you do need something properly made, because if you're, for instance, if you've got sleep apnea and you're 30 years old, and I do see people who are 30 years old, even 20 years old with sleep apnea, and I just make them a temporary appliance, it has to last them for the next 60, 70, 80 years of their life. If it's something very soft that's going to break, they're most likely not going to be able to use it long term. So I'm now going to go into the custom dental made masses out there on the market. And there's many different designs out there. Now, I haven't used all these designs. The designs I use are these dorsals or EMA strap designs. Though all these designs do work and they have been used in the literature, and I have met other dentists who use all these designs as well very effectively. So the first design is this tap design. It goes on the top and bottom jaw, and it has this screw at the front. Now, how it works is you turn this screw, and when you turn the screw, it pushes the bottom jaw forward. Now, there's these strap designs. How these strap designs work is they all pretty much work in the same mechanism. They all just look a bit different over time. So I've used all these actually. And how they work is they have these arms straps on the side. And with these straps, you can take these straps off and you can use smaller straps. When you put a smaller strap on, it pushes and holds your bottom jaw more and more forward. Okay, so this is a very popular design, the dorsal design, and this is about 70 or 80% of my patients use this dorsal design. So with this design, how it works, it's called a dorsal because it's got this dorsal fin on the side, and basically this fin helps push and hold your jaw forward. And there's a few ways you can push your jaw forward, like with this one, the Somnodent, there's a little screw, you can turn the screw to push your jaw forward. With these white ones that I use, you can take these little tabs out of the slot and put larger tabs in, which will then push your bottom jaw more and more forward. Now, there's also these single arch monoblock devices. So I use this one in some patients. They're not as effective in holding the mandible forward, but they're better than nothing. And I tend to use these in patients who have jaw pain or clicking jaw joints or TMJ cases where the TMJ, which is the jaw joint, is hurting. Now, the reason I use these is they're less bulkier and more comfortable. You can see they're a lot smaller. This one only goes on the top jaw rather than the top and bottom jaw. And it has this ring at the front, and this ring locks behind the bottom front teeth to hold your bottom jaw forward. So if I have a patient who has jaw pain or headaches or a clicking jaw joint and they have sleep apnea, I may not make them a mass like this. I may make them this first and wait until their jaw pain and the clicking is gone. Once the jaw pain is treated properly, and if we still need to go to a different mass, I will then change this to one of these proper masses. Though I have used these single arch monoblock devices on lots of mild and moderate sleep apnea patients and brought their AHI down to 0. So in those situations, I don't need to make them a different design. They can just continue using this very effectively. And then there's also this design, which is very new to the market, called the Ventus, the O2 vent. Now, I personally don't like this design too much for a few reasons. So the main gimmick with this device is it has this duck bill at the front, which opens the mouth so you can breathe through the mouth. Now, the reason they have this is most people who have sleep apnea have some difficulty breathing through the nose and are mouth breathers. Now, I have huge issues with this because I talk to all my patients about eliminating mouth breathing, and I actually teach them and help them stop their mouth breathing and start breathing through their nose. Because as humans, we should ideally breathe through the nose. The mouth was made for eating and talking. The nose was made for breathing. If we're going to breathe through our mouth, we'll then have to figure out how to eat and talk through our nose. So with this device, it's actually trying to promote mouth breathing. It's sort of like saying, I go to my doctor with a sore right arm and I say, Doc, my right arm is hurting. Can you fix it? Doc looks at me and says, don't worry, don't use your right arm anymore. Just use your left arm for the rest of your life and keep your right arm as it is. That's how I see this. If I can't breathe through my nose and I'm a mouth breather, I want to be able to breathe through my nose. I want to stop my mouth breathing. If my arm was hurting, I would do anything to make my arm get better, whether it be physio or medications or even surgery. The same should be for nasal breathing. If I can't breathe through my nose, I shouldn't just go to mouth breathing. I should do anything I can to breathe better through my nose, whether it be medications or exercises or even surgery to help fix the nose. So we should all be nasal breathers. And I talk to all my patients about this because quite often, if they can't use CPAP or they can't use a MAS, it's because they can't breathe through the nose. And then they're left in limbo thinking, I can't do anything. So there are things we can do to help them breathe through the nose. Now, the reason we should breathe through our nose is the nose is designed to help filter the air. It's got mucus and hairs inside the nose, which filter out all the bacteria and pollutants. The nose, when we breathe through the nose, it also stimulates our sinuses. Now, our sinuses help create and release nitric oxide, and that's the only way we get nitric oxide in our body. Now, nitric oxide is so important to us. Why is it important? Nitric oxide is a vasodilator. We don't get nitric oxide if we breathe through our mouth. Now, vasodilation is when our blood vessels dilate and then allows more blood and oxygen to flow around our body. Now remember, one of the consequences of sleep apnea is heart attack, stroke, and high blood pressure. If you're a mouth breather, you're going to have a much lower chance of correcting your blood pressure and heart issues. If you're a nasal breather and you get that nitric oxide release, you then have a much greater chance of reducing your blood pressure and fixing any heart issues. Nitric oxide is also anti-inflammatory. It also helps destroy viruses and parasites. And for the men out there, it helps with erectile dysfunction. So let's go into a little anatomy of the other end. How do we get an erection? An erection is when we get vasodilation to the penis. If we don't get enough nitric oxide then we won't get enough vasodilation. If we don't get any vasodilation, we're going to have erectile dysfunction. So this is why nasal breathing is so important to us. Nasal breathing also helps calm and relax the body and helps with our posture. So lots of the patients I see are for sleep apnea and jaw pain. Now, their jaw pain can also have headaches and neck pain because they're not breathing properly. Now, if you're a mouth breather, you tend to breathe using your chest, shoulder, and neck muscles. These aren't our breathing muscles. The chest, shoulder, and neck muscles are designed to help move our chest, shoulders, and neck. Our main breathing muscle is the diaphragm in our tummy. So if we're a mouth breather, we won't be using the diaphragm. We'll be using our chest, neck, and shoulder muscles, which will then alter our posture. And then this will also make us have neck pain, back pain, headaches, etc. If we're a nasal breather, then we use our diaphragm and we stop overworking these other muscles and can help correct our posture and also help with postural pain. And lots of the patients I see with sleep apnea or jaw problems, I train them to be nasal breathers with their MAS. Once they become nasal breathers, most of them start telling me that their neck pain and jaw pain and back pain starts going away as well. So this person is Dr. Christian Guilleminot. This guy is the father of sleep apnea. He was actually the researcher who first discovered sleep apnea. Now, sadly, Dr. Guilleminot passed away last year. But in this conference just last year about sleep apnea and orthodontics, he said establishing 100% nasal breathing is essential endpoint to eliminate OSA. So his dying research and message was that to treat sleep apnea effectively, we should be breathing through our nose. So that's why it's very important, whether using a MAS or a CPAP, that you shouldn't be mouth breathing, you should be breathing through your nose. So with all these different design masses that I've just shown you, you will have noticed there's a few different materials out there in terms of how they look. So the two main materials out there is this white nylon and this clear acrylic. Now, acrylic has been around for ages in dentistry. Nylon has only been around for the last 5 to 10 years, and I've been using these nylon splints for around 7, 8 years now. So I prefer using nylon over acrylic. Acrylic is weaker. So acrylic is very brittle, and to make acrylic work and stronger, we have to make it very thick. That also means that it's going to be very bulky. A nylon splint is maybe about 1.5 millimeters thickness, whereas acrylic is about 4 millimeters thickness. And nylon is generally more comfortable because it's much skinnier and fits better inside the mouth. Now, these are some photos of an acrylic splint with a nylon splint, and you can just see the difference in the thickness of the material here. You can see how much thicker this acrylic is compared to the nylon. This nylon is only about 1.5 millimeters thick. And this table sort of explains the differences and pros and cons between the different materials we've got out there. So in ball and bite appliances, they're about 5 to 7 millimeters thick. Acrylic is about 4 millimeters, nylon about 1.5 millimeters. Ball and bite appliances are very weak. They don't tend to last well. Acrylic is okay, but they are brittle and can break. And nylon is very strong. In terms of the strength of nylon, I went to a conference last year where they had a nylon splint and an acrylic splint. They put those splints on the road and they ran over it with a car. The acrylic splint shattered into pieces. The nylon splint didn't break at all. So nylon is definitely a lot stronger. Now, the acrylic splint tends to be quite comfortable, but nylon is a lot more comfortable because it's a lot more smaller. The fit of acrylic is a bit less than the nylon because it's a bit thicker. And both acrylic and nylon are very effective in the research because they're actually made by a dentist trained in this. Whereas the ball and bite ones, they're not that effective because they're not properly monitored. Now, ball and bite is not research supported, whereas dental-made splints in acrylic and nylon are research supported. And the AASM actually does recommend using a nylon or acrylic splint. In terms of longevity, ball and bite splints, you're generally looking at a couple of months. Acrylic, around 3 years. Nylon, I'm generally finding at least 5 years plus. So generally, I've seen people who've had an acrylic splint for over 20 years and it's perfectly fine. So they are generally very long lasting, whether they're acrylic or nylon. So most of you out there are probably sufferers of sleep apnea, just like myself. And the most important question you're probably going to be wondering is, how much is one of these splints going to cost me? And is it going to be much cheaper than a CPAP? So if there's any dentists watching this, they might get a bit uncomfortable because I'm going to be revealing all our secrets of how much we actually charge here. But I believe it's perfectly fine for you patients to know our complete transparency of how much we charge and why we charge what we charge for these splints. So the rough average price for one of these masses, you look in Australia, looking about 1,500 to 2,500. And I have come across a few dentists who charge a bit more or a bit less, so the fees are variable out there. So looking at the over-the-counter ball and bite splints, we can see that they do go for quite a bit of money still, about $130 to $350. And then if we look at if we're comparing with CPAP, CPAP is roughly the same price as a MAS. Like the machine itself can vary from a $1 to $2 grand. Then when you start adding in face masks and everything else, you can be looking at maybe $2.5. I've had some patients who told me their CPAP machine costs about $3,000 to $4,000. So there is really quite a distinction in prices here. So then we have to think, why does this piece of plastic that my dentist given me cost so much? Whereas this CPAP machine has got all these electronics, it's got these masks. It seems much more worthwhile investment of money. Well, when we make a splint, there's quite a few steps involved. So when we normally take a mold off your mouth first, or a scan of your mouth. And if we take a mold, depending on what the material we use, the impression material to take a mold can cost anywhere from $50 to $150, maybe even $200. After we take a mold, we then send to a lab, and the lab then pours up models or 3D prints these splints and make them up for us. Now the labs, they can charge anything from $400 to $800. And I was just talking to a dentist just last week, and he was telling me his lab charges him $1,000 to make his splint. So you can already see it's already costing a dentist about $1,000, maybe over $1,000 to make one of these splints. And you have to remember as well, we're actually treating a health issue. I like to relate a mandibular advancement splint to similar to giving someone braces. When we give someone braces, we put the braces on their teeth, and then we normally see them once a month. We don't just put the braces on and say, bye-bye, I'll see you in 2 years' time. That's not how it works. MAS is the same thing. When we give you a MAS, we don't just say, bye-bye, I'm never going to see you again. We normally do review you. We want to make sure it's working. We have to remember, we're treating a health issue. We're not just giving you a piece of plastic and saying goodbye. We're offering you a service. And normally, when I give a MAS to someone, I normally see them maybe around 4 or 5 times within the first 12 months to make sure things are going okay, that it's working, adjusted, etc. And that's the fee I use. I charge about $1,950 to $2,500, depending on what design I use. And the fee I charge there, that covers all my reviews and the cost of the splint. So really, whenever you come in for a review, you won't be charged anything extra. So you have to think, we're actually offering a service here. We're not just giving you a piece of plastic. Yes, it is a piece of plastic. It's not as fancy as a CPAP machine, though we're also offering you our health advice and looking after you and making sure it's working. Because at the end of the day, we want to make sure that we're actually fixing your problem. Remember, sleep apnea can be related to heart attack or stroke, high blood pressure, diabetes, mood disorders, etc. And if you just take this splint and go away and we never see you again, we'll never know if you're actually getting better. You could have a heart attack because your MAS wasn't working properly and no one was checking you. And that's where the importance is in having a properly made splint monitored by a dentist rather than just using an over-the-counter splint. So the MAS may not fix everything. As I mentioned before, there can be other issues going on. You may be a mouth breather. You may be overweight. You may have nasal issues. There may be a deviated septum. You may have large tonsils or adenoids blocking your airway. So if there's any of these issues going on, the MAS may not fix everything. And when we use a MAS, we want to take your AHI down to 0 or at least below 5. So If we're using a MAS and we can't get it below 5, that's where we may need to look at the nose. We may need to look at the tonsils. We may need to look at the weight. And that's why it's so important to have regular reviews and checkups. So I talk to all my patients about these issues. I talk to them about take-home remedies they can do. They can use these nasal cones to open their nose. They can use nasal sprays. They can use these little breathe right strips to open their nasal passage. I talk to them about diet and exercise. I talk to them about sleeping posture and position. And it's very important to regularly monitor your OSA with not just your dentist, but your doctor. So if you had high blood pressure or diabetes, you would normally see your doctor at least once a year to get a regular check and make sure it's being controlled. Sleep apnea is exactly the same. We want to regularly check it and make sure it's being controlled properly. So in closing, where do we see the future of sleep apnea management? Before I ask, it's a war or a battle between CPAP and oral appliances, and who's winning? Well, I think we're asking the wrong question here about whether we should be using CPAP or MAS. I think we should be asking who's winning between us and sleep apnea. And at the moment, I reckon sleep apnea is beating all of us. Because I was diagnosed with sleep apnea when I was 23 years old. And then the only thing I got told was I have to either use a CPAP or a MAS, and I have to use it for the rest of my life. So 23 years old, it's like, oh, I have to use something for the next 60, 70, 80 years of my life whenever I go to sleep. That's not really great fun. So I reckon there's going to be lots of changes in the future in terms of how we'll be able to treat sleep apnea. And in the dental world, there's lots of research looking into ways to get us off having to use a CPAP and off having to use a MAS. There's research into looking into exercises for the jaw and the lips and the tongue to strengthen them. As I said, there's orthodontics being used to help grow and push the jaw forward and create more space. And there's more new surgeries which are becoming less invasive to also open up the airway in both the tongue and both the oral and nasal passages. So I'm very excited as to where the research will be going in the next 10, 20 years of how we'll be able to treat sleep apnea. So thank you very much for your time. Please support Sleep Disorders Australia. They're a great group. They're all run by volunteers. It's a charitable non-profit organization. Hope to promote and create more awareness of this of sleep disorders. Now, if any of you have want to get in touch with me, please feel free to send me an email or check out my clinic website. And I do also teach lectures to dentists if there's any dentists interested to learn more about this topic. So that's basically all I have to talk about tonight. I'm just going to end this presentation and go into Facebook, and hopefully we can start going through some questions and answers. So I'm going to stop sharing the screen and hope it will start showing me up here now. Let's see, where's the screen?